Good morning. My name is Jamie Sparling, and I'm an anesthesiologist at Massachusetts General Hospital. I'm here today to speak with you about anesthesia considerations for tracheal resection. Our learning objectives for this talk are first to review some of the background information for tracheal resection surgery, including the normal tracheal anatomy, the etiologies of tracheal stenosis, its epidemiology, and pathophysiology. Next, we'll review some of the key surgical elements of tracheal resection and reconstruction surgery. And finally, we'll apply these to consider options for airway management and other anesthesia considerations during tracheal resection. First, we'll review normal tracheal anatomy. The adult lower airway extends from the true vocal cords to the level of the carina. The first 2 centimeters of the trachea, extending from the vocal cords to the cricoid cartilage, are considered the subglottic airway. In normal adults, the narrowest portion of the upper airway is located at the level of the vocal cords. However, this is not necessarily true in patients with tracheal stenosis. The trachea itself is a tubular structure lined by mucosa, with walls consisting of 16 to 20 incomplete cartilages and the posterior fibromuscular membrane. The tracheal cartilages are incomplete rings that extend anterior laterally with a posterior deficiency that's bridged by that flat muscular wall. Normally, the posterior wall of the trachea bulges into the lumen during expiration and coughing, which can be visualized during routine bronchoscopy. These changes are exaggerated in patients with tracheal malacia. The normal adult trachea is about 10 to 11 centimeters long and descends from the larynx at the level of the 6th cervical vertebrae to the carina at the level of the 5th thoracic vertebrae. Approximately 1/3 of the total tracheal length is extrathoracic, that is the component above the suprasternal notch. The remaining 2/3 are intrathoracic. Normally, the trachea is quite mobile, and its length can rapidly change with respiration and neck movement. With deep inspiration, the carina may descend to the level of T6, and this is visible as tracheal tugging. This may create difficulty gaining control of tracheostoma in a patient with acute respiratory distress. Depending on the degree of neck flexion or extension, the trachea becomes more mediastinal or cervical respectively. The use then of neck extension and flexion in particular is an important aspect of both the surgical exposure and subsequently the postoperative healing and tracheal resection and reconstruction. The external diameter of the trachea is normally around 2 centimeters in adult men and 1.5 centimeters in adult women. In children, of course, it is smaller, but also more mobile and more deeply placed. The cross-sectional shape of the tracheal lumen may be round, lunate, or flattened. The trachea divides into the right main and left main bronchi. The right main bronchus is more vertical than the left and quickly divides into the right upper lobe bronchus and continues as the bronchus intermedius, which then divides into the right middle lobe and right lower lobe bronchi. The right upper lobe takeoff may be displaced at the level of the carina or the lower end of the trachea, which creates difficulty with right lung isolation. The left main bronchus is narrower and less vertical than the right. It's around 5 centimeters in length, and it divides into the left upper lobe and left lower lobe bronchi. The trachea benefits from both rich vascular supply as well as rich lymphatic drainage. However, the blood supply comes from the external aspect, so tracheal mucosa is sensitive to pressure from internal forces such as endotracheal tubes or tracheostomy cuffs. This is enhanced in patients with microangiopathies, including diabetes mellitus and prior radiation therapy, which can compromise the microvascular blood supply and impair anastomotic healing. The blood supply approaches laterally via a number of branches. These include branches of the inferior thyroid artery, the subclavian artery, the innominate, the internal thoracic arteries, the first intercostal, and the bronchial arteries. Because of this diverse blood supply, maintaining the blood supply to the trachea by avoiding circumferential dissection is one of the principal tenets of tracheal resection and reconstruction surgery. The larynx is innervated entirely by branches of the vagus nerve. Many of you will remember back to your board studying but the cricothyroid muscle is innervated by the external branch of the superior laryngeal nerve. The remainder of the laryngeal muscles are innervated by the recurrent laryngeal nerve. Additionally, tracheal muscle fibers, that is in the posterior membrane, are innervated by the recurrent laryngeal nerve. Finally, fibers arise from the middle cervical ganglion, which join with connections from the recurrent laryngeal nerve to comprise the sympathetic innervation of the trachea. All of these nerves are subject to involvement in the tracheal pathology, as well as injury from surgical manipulation. Keeping in mind these features of normal tracheal anatomy, we will move on to the development of pathologic tracheal stenosis. During normal quiet breathing, airflow through the trachea is laminar and is described by the Poiseuille equation, wherein volumetric airflow is proportional to the pressure differential and the radius to the fourth power. It is inversely proportional to the fluid viscosity and the length. As the radius decreases, airflow can be augmented by increasing the pressure gradient, that is, through increased work of breathing. Symptoms of stridor and dyspnea tend to correlate with the degree of tracheal stenosis. Generally, dyspnea occurs around 50% stenosis. Keeping in mind that the normal airway is 1.5 to 2 centimeters, this is generally around 8 millimeters or so. Stridor at rest tends to occur when the airway narrows to around 5 to 6 millimeters. The severity of symptoms and the patient's physiologic compensation depends on a number of factors, including the location of the stenosis, its etiology, and the rapidity of its development. With increasing degrees of stenosis, small additional changes due to airway edema, secretions, or airway bleeding are poorly tolerated. Traditionally, flow volume loops have been used to diagnose and characterize airway obstruction, such as tracheal stenosis. The classical teaching is that fixed stenosis, which is the more common case, attenuates both inspiratory and expiratory peak flows, as shown in this figure. Dynamic collapse, however, occurs in different phases depending on the location of the lesion. Extrathoracic compromise occurs during inspiration, when airway pressure is below atmospheric pressure. Intrathoracic compromise occurs during expiration, when thoracic pressure is above the tracheal pressure. Because of this, spontaneous ventilation is better tolerated with intrathoracic lesions because thoracic pressure drops below tracheal pressure during inspiration. In current practice, the role of flow volume loops has been de-emphasized. Imaging has improved, and together with careful clinical observation and questioning, we can elicit much of the relevant dynamic respiratory components and inform the best anesthesia induction plan for the patient. There are a number of etiologies of tracheal stenosis. The most common by far, representing about 3/4 of cases, is post-intubation or post-tracheostomy stenosis, which we'll dive deeper into in a moment. The second most common etiology is idiopathic or inflammatory, of which granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis, is one subtype. Tracheal stenosis can also occur due to malignancy, and this represents about 8% of cases. This may occur as a primary tracheal malignancy, most commonly squamous cell carcinoma or adenoid cystic carcinoma, or less commonly, it may be narrowed by a metastasis from a distant primary. Finally, the remainder of cases are made up of other causes, which may include traumatic laceration or dislocation, intrinsic or extrinsic hematoma compression, congenital abnormalities such as vascular rings, and burn or inhalation injury. Post-intubation tracheal stenosis generally occurs after ICU intubation rather than after brief intubations for general anesthetics. It may present as two different types of stenosis. Glottic or laryngeal stenosis can develop in as little as 2 to 5 days of intubation. The stenosis is located posteriorly in the interarytenoid area, where the endotracheal tube rests in supine patients due to gravity. Tracheal stenosis, on the other hand, tends to occur in patients with intubations exceeding 1 week. It occurs when the cuff pressure exceeds the mean capillary pressure usually around 20 centimeters of water. It is associated with inflammatory changes, including cellular necrosis on pathology, scarring, and a characteristic webbing appearance on bronchoscopy. The overall rates of post-intubation tracheal stenosis have improved with the use of low-pressure, high-volume cuffs. They are seen after any duration of intubation, but longer durations are a risk factor. Other risk factors include higher endotracheal tube cuff pressures, larger endotracheal tubes, peritube infections, advanced age, female gender, a smoking history, obesity, and diabetes, particularly when poorly controlled. The mechanism of injury is initial mucosal injury from ischemia, followed by a chronic inflammatory reaction and ultimate formation of granulomas. Symptoms become apparent approximately 1 to 3 months after extubation. There have been multiple case reports following intubation for COVID pneumonia. The first two I'll describe are from the United Arab Emirates, and the second two are from Japan. The first case is that of a 35-year-old gentleman who presented with dyspnea and stridor 4 months after a 21-day intubation for COVID. He was found to have a 3-centimeter long stenosis, occluding 70% of the lumen, a half a centimeter below the cords. The second gentleman, pictured in the upper images, presented with dyspnea and wheeze 6 months after a 2-month intubation. He was found to have a 2.5 centimeter long stenosis, 80% occlusion, 2 centimeters below the cords. Each of these first two patients was initially treated with tracheal dilation and ultimately resection and reconstruction surgery. The third patient was a 42-year-old gentleman with dyspnea about 7 weeks after an 8-day intubation for COVID. He had laryngeal stenosis with swelling of the vestibular fold and granulation tissue on both the superior and inferior aspects of his glottis. And finally, the fourth patient, shown in the lower image here, presented with dyspnea and dysphagia 7 weeks after a 54-day intubation and tracheostomy for COVID. He was found to have granulation tissues occluding the airway at the level of the prior tracheostomy. These latter two patients were managed with tracheostomy below the level of the stenosis and removal of the granulation tissue surgically. The overall incidence of tracheal stenosis following intubation for COVID is yet to be described, but these early reports likely represent just the tip of the iceberg. Because of this, it is imperative that anesthesiologists be prepared to manage patients during these challenging cases. The anesthesia management begins with a careful preoperative evaluation. In clinical evaluation of the patient, we ascertain the development or aggravating factors for their dyspnea, including whether it occurs with what degree of exertion versus at rest. We question the patient about inspiratory versus expiratory components of both their dyspnea and stridor, and whether there is a positional component. In addition, we conduct a routine airway exam to predict both laryngoscopy difficulty as well as difficult mask ventilation. It is helpful to review prior bronchoscopy notes to determine the location and degree of stenosis, to know the timing of prior interventions, with the caveat that obstruction can worsen quickly and unpredictably. It is also very useful to review imaging notes when available. High-resolution CT of the neck and the upper thorax, with or without 3D reconstruction, has largely replaced the tracheal series X-rays that were used previously. In most patients, an MRI is unnecessary, and it may be dangerous due to the remote location and the long length of the procedure in a patient with a critical airway. And while we reviewed them earlier, dynamic flow volume loops probably offer little value in addition to the careful clinical exam that we spoke of. There are several relative contraindications to proceeding with tracheal resection. The first is severe pulmonary dysfunction. This is because the need for postoperative intubation and ventilation may compromise healing of the anastomosis. Additionally, the patient must be able to tolerate brief apneic periods if cross-field ventilation is used intraoperatively. In these patients, the routine approach is to perform a tracheostomy bypassing the stenosis, wean the patient from the ventilator, have them undergo pulmonary rehabilitation and become medically optimized, and then electively return for tracheal resection and reconstruction. Additionally, steroid dependence or a history of prior head or neck radiation therapy are also relative contraindications. This is because they may interfere with wound healing and increase the risk of anastomotic dehiscence, which comes with severe morbidity and even mortality. One of the most important considerations for the anesthesiologist is the choice of airway management technique, and this requires careful planning and coordination between surgical and anesthesia colleagues. Schwerin and colleagues recently conducted a systematic review and meta-analysis, reviewing 59 publications describing airway techniques for tracheal resection surgery. They categorized approaches as conventional or novel airway techniques. In the lower left-hand corner, they've categorized the publications over time. You'll see in the last decade and more, increasing amounts of novel airway techniques have been described. In their analysis, they categorized conventional airway techniques as those including traditional oral endotracheal intubation, preoperative tracheostomy, cross-field ventilation, jet ventilation bypassing the stenosis, or pre-induction institution of cardiopulmonary bypass through peripheral cannulation. There were a number of novel airway techniques described. Several of these were regional techniques with cervical epidural catheters, thoracic epidural catheters, bilateral cervical plexus blockade, or local infiltration. Each of these, however, was supplemented with IV anesthesia and/or analgesia, and many of them converted over either to a supraglottic airway technique or to cross-field ventilation once the tracheal incision had occurred. There have, however, been several reports of supraglottic airways used as the sole mode throughout the surgery. There have also been new development of extracorporeal support. There's been 17 patients described with ECMO for tracheal resection surgery, one of which was used as a rescue technique after other forms of airway management failed. The remainder were used up front. About half of these were used only temporarily until cross-field ventilation could be established, while the remainder were used throughout. Those that were used throughout were primarily for low tracheal resections with carinal involvement, and accordingly they were VA ECMO rather than VV. All of the patients described in the literature have been weaned from ECMO by the end of the resection. Finally, there's 2 publications that describe extracorporeal removal of carbon dioxide used together with apneic oxygenation. These patients, however, have suffered a high rate of postoperative ARDS. In our institution, we've used 2 primary modes of airway management, traditional cross-field ventilation, as well as a newer technique utilizing jet ventilation. Regardless of the mode used, we are prepared with an assortment of small diameter endotracheal tubes, a PD bronchoscope, and various sizes of rigid bronchoscopes on the surgical setup. For all of these patients, generally 1 to 2 peripheral IVs will suffice as long as large blood loss is not anticipated. It's usually helpful to have a backup IV because the arms tend to be tucked and most of these patients undergo a TIVA anesthetic. Our anesthesia setup for cross-field ventilation cases is notable for the following. We retrieve additional extension tubing to connect the circuit through the cross-field ventilation circuit. We place a stopcock into our sampling line so that we can easily switch between the circuit connecting the oral endotracheal tube and that coming off of the surgical field for cross-field ventilation. We label each of these circuits and all of their components so that it's readily apparent to the anesthetist which of the modalities we're employing. And you can see in the lower right-hand corner here, both the sterile circuit, that is the black one here, coming off of the field, as well as the traditional circuit, which is the lower one here. Both of these are used throughout the surgery. The remainder of our setup includes standard ASA monitors. We don't routinely use an arterial line unless it's specifically indicated due to patient factors. These are an important consideration for lower tracheal resections, however, due to the risk of nominate compression. They may also be considered for patients with borderline pulmonary reserve, for whom serial blood gas analysis would be helpful, as well as for patients where jet ventilation is employed without the opportunity for sampling of end-tidal CO2, or if this is felt to be unreliable. We use prostate EEG monitoring, that is a SED line or a BIS monitor, due to the presence of TIVA as our primary anesthetic. And we keep the patient paralyzed throughout, and so we use a quantitative train of 4 monitor. A Foley catheter may be placed depending on the anticipated length of surgery for close monitoring of urine output. Positioning tends to be supine with the arms tucked, and a thyroid bag is placed under the patient's shoulders. It's critical to ensure that the head's not floating in order to prevent hyperextension injuries. In terms of anesthesia induction, while many sources advocate for an inhalation induction, and this is our traditional teaching, we found that IV induction is generally well tolerated, particularly with the setup we have described, and IV induction is used in the vast majority of our cases. Moving on to the surgical procedure itself, the cases started with rigid bronchoscopy to ascertain the location and extent of the tracheal resection, to ensure the health and function of the vocal cords, and to identify any areas of active inflammation which may necessitate deferring the case. It also identifies any areas of tracheal malacia. The surgeon may dilate the trachea at this time, and then we intubate with the largest size endotracheal tube possible. Then the surgery proceeds with a transverse surgical incision, dissection, and mobilization of the trachea. At this time, the trachea is incised. This requires careful coordination between the surgeon and anesthesiologist to avoid puncture of the endotracheal tube. A red rubber catheter is sutured to the distal endotracheal tube tip, which is then withdrawn under direct visualization in the field. The second incision is made at the distal end of the lesion, and traction sutures are placed in order to lift the trachea up off the esophagus and protect the important neurovascular structures that we spoke of earlier. At this time, the surgeon sterilely intubates the distal trachea in the field. He hands that off the field to the anesthesia team, where we verify the presence of end-tidal CO2 and verify chest rise. During this time, we're able to hand ventilate the patient, and we pause when the endotracheal tube is removed from the distal airway. The surgeons proceed with circumferentially dissecting the area that will be removed. At this time, we test the approximation with a brief period of neck flexion and then return the patient to cervical extension. The sutures are then meticulously placed through the posterior then the anterior wall of the trachea. And during this time, ventilation is frequently interrupted, highlighting the need for close coordination. While we're ventilating, we tend to hyperventilate to some degree in order to extend the apnea time. Once all of the sutures have been placed, the surgeon reintubates with the oral endotracheal tube by guiding the tube back into the trachea using the red rubber catheter. Then the anastomosis is completed, the head is placed into flexion, and 2 leak tests are conducted. The first is to assure an adequate tracheal lumen by demonstrating a leak of air around the mouth when the cuff is down. The second is to assure an airtight anastomosis by demonstrating the absence of bubbling in the field during a recruitment breath. During closure, we avoid respiratory depressants and lighten the anesthetic. The thyroid bag is removed and a chin stitch is placed to maintain the patient in gentle cervical flexion. Then the patient is extubated awake and transferred to the surgical ICU. In recent years, we've adopted a number of modifications to enable jet ventilation. In these patients, the initial airway management is with a laryngeal mask airway. Afterwards, we place a conduit capable of jet ventilation through the LMA, and this is removed at the end of the case, and we emerge the patient on an LMA. The conduits that we've trialed for jet ventilation include the Bureau jet ventilation catheter, the Aintree airway exchange catheter, the Hunsucker catheter, and various sizes of a Cook airway exchange catheter. Now I'll briefly describe the troubleshooting that we've gone through, as well as the strengths and limitations of the different conduits. The first option was the Hunsucker catheter, which had the advantage of a very narrow profile with an outer diameter of only 4.3 millimeters, which provided good surgical visualization. There's also the presence of an end-tidal CO2 sampling line, and there's a cage to avoid positioning against the wall, causing barrel trauma. The disadvantages we found in our practice, including kinking of the catheter and occlusion of the sampling line by secretions or blood. We also found difficulty with placement because it cannot be driven with a bronchoscope. The next iteration was using an Aintree airway exchange catheter. The advantage of the Aintree is that with an inner diameter of 4.7 millimeters, it can be driven over a PD bronchoscope and easily advanced through the LMA into the trachea. Its disadvantages were that it was bulky, impairing surgical visualization with an outer diameter of 6.3 millimeters, and there is no sampling line to ensure adequate ventilation by monitoring end-tidal CO2. The third iteration was moving on to the Biro catheter, which is perhaps the happy medium between these two. The Biro catheter comes in either a 40 or 70 centimeter length and has a 4 millimeter outer diameter. Because of this, its narrow profile optimizes surgical exposure, and we benefit from having an end-tidal CO2 monitoring line. The only disadvantage we found in our practice is that it cannot be driven over a bronchoscope, so at times it can be difficult to pass. With a well-seated LMA, however, this can be achieved without much difficulty. Here are two illustrations. On the left, the surgical field, you can see that the Biro catheter provides an adequate view for the surgeons during their exposure and while they're placing their anastomotic sutures. On the right is shown our anesthesia machine, where you can see our CO2 sampling line, where we have a relatively reliable tracing. So to conclude, we've seen that tracheal stenosis can occur related to a number of etiologies, most importantly post-intubation or post-tracheostomy, which may be emerging as patients recover from COVID pneumonia. It may also occur due to idiopathic or inflammatory causes or as a primary metastatic tumor. The incidence of patients that have been affected by post-intubation tracheal stenosis due to COVID is yet to be determined, but we expect it to be a growing issue, highlighting the need for anesthesiologists to be prepared. Finally, there's been a myriad of different approaches to managing the airway for tracheal resection and reconstruction surgery. We described our institutional experience with traditional cross-field ventilation, as well as newer techniques working with a laryngeal mask airway and passing a jet ventilation catheter, as well as troubleshooting these techniques and some of the advantages of the different conduits. There's also been many other new approaches using regional anesthesia or extracorporeal support, which have emerged in the literature. There, however, is little guidance and further research needed for patient selection to utilize the different approaches. Here are the references from my talk. Thank you for your time and attention.